Hello, everyone. Good morning, good afternoon, good evening, wherever you are. We'll just get started very shortly in about 3 minutes. All right. Good afternoon, everyone, and welcome. My name is Javier Amador Castañeda, and I am a respiratory care practitioner at Columbia University Irving Medical Center in New York. I am also one of the co-chairs for the ARDS Innovation Knowledge Education Group, along with my colleague, Dr. Mina. I do not have any conflicts of interest to disclose this time. Dr. Mina, if you could please introduce yourself and state any conflicts of interest.
I am Brochard. I'm the Chairman of Medicine and Chief of Pulmonary Critical Care at Northern Worcester Hospital in Worcester and part of Northwell Health. It's a pleasure to be here, and we have a great speaker, and this is going to be very informative webinar.
Thank you, Dr. Mina. And on behalf of our CAC leadership and SECM, we're proud to welcome you to today's webinar, Precision Mechanical Ventilation in ARDS, from lung protection to personalized care. This one-hour event continues our tradition of engaging the foremost experts in ARDS research and clinical practice. Today, we're privileged to host Professor Martin Tobin and Professor Laurent Brochard, two of the most influential voices in mechanical ventilation. Each will deliver a 20-minute lecture followed by a 15-minute live Q&A session. It is now my pleasure to hand things over to our guest moderator, Dr. Richard Grindike, who will introduce our speakers. Dr.
Thank you. Thank you, Javier. So my name is Richard. I'm a pulmonary and critical care physician, also from Columbia University in New York City, and currently doing a research fellowship in Toronto. I have no conflicts of interest. Before we begin, just a few quick housekeeping items. Today's session is being streamed live on Zoom, LinkedIn Live, and YouTube. And if Zoom reaches capacity, you can continue viewing on one of the other social platforms. If you could please enter your questions in the Zoom Q&A box or in the comments on LinkedIn and YouTube, and we will collect them and sort of as the discussion goes, collate them for discussion at the end of the talks. And then just to note that the webinar is being recorded and the full session will be available on our platforms afterwards. It is now my honor to introduce our first speaker. So Professor Martin Tobin is Professor of Medicine at the Heinz-Weige Hospital and Loyola University Medical School in Chicago. He has published extensively on mechanical ventilation, control of breathing, respiratory muscle function, and other areas of pulmonary and critical care medicine. Between 1999 and 2004, Dr. Tobin served as editor-in-chief of the American Journal of Respiratory and Critical Care Medicine, and he's also the editor of Principles and Practice of Mechanical Ventilation, which has been published in 3 editions. He is one of the world's foremost experts in mechanical ventilation and respiratory failure, and his 1991 paper describing the Rapid Shallow Breathing Index is just one example of the seminal work that he has done that informs our practice every day in the ICU. Welcome, Professor Tobin, and the floor is yours.
Thank you very much, Richard. Okay. So I point out that I receive royalties for 2 books on critical care published by McGraw-Hill. Javier Amador Castaneda has asked me to address 3 topics on lung protective mechanical ventilation in ARDS: past lessons, present practices, and future directions. Starting with the past lessons, lung protective ventilation serves as a springboard for 3 important lessons across every branch of medicine. Whenever clinicians are asked about lung protective ventilation, they usually refer to the ARDS network, or CT, that uncovered an increase in mortality with tidal volume of 12 versus 6 ml per kilogram. But this study, published in 2000, was not the fountain of new ideas. Rather, it was the culmination of many years of research. 10 years beforehand, Keith Hickling published a retrospective study showing greater survival with deliberate lowering of tidal volume and permitting PCO2 values as high as 126. Hickling's article was a mere retrospective case series in 50 patients, yet it profoundly changed medical thinking. The Carmichael survey by members of the ARDS network showed that clinicians were already avoiding high tidal volumes before 1996. Retrospective case series are judged ipso facto inferior to randomized controlled trials. It's sacrilege to say otherwise. Advances in science, however, are determined by the novelty of a hypothesis, conjuring up an idea not previously thought, and reporting findings that will be judged convincing by subsequent investigators. In his landmark book, The Structure of Scientific Revolutions, Thomas Kuhn put forward a framework for deciding which papers are seminal in advancing a field. Kuhn said, research in the field is dominated by long periods of normal science, punctuated intermittently by sharp revolutions. Normal science is the Me Too type of research, exemplified by RCTs that repeat the same design from one RCT to the next. Kuhn contended few people realize how much mop-up work there is to do. Mopping up operations are what engage most scientists throughout their careers. So the first past lesson is that the paradigm shift for mechanical ventilation in ARDS was generated by Hickling's 1990 retrospective report, not by the network RCT in 2000. Following publication of the ARDS net report, guidelines promoted the use of 6 ml per kilogram, although 6 ml per kilogram has never been shown to be superior to 11 ml per kilogram or anything in between. When the network study was published, I wrote the tie-in editorial. The only that discriminated between the two positive RCTs, the Amato and network studies, and the 3 negative RCTs, was the average airway plateau pressure. Patients with significantly increased mortality had plateau pressures of greater than 32. I recommended that tidal volume should be set to avoid a plateau of 32. I specified that setting tidal volume in terms of milliliters per kilogram would be misguided because it ignores the physiological variable plateau pressure that signals alveolar injury. I used the analogy of a patient with a hypertensive emergency where therapy is based solely on milligram dosage with disregard to changes in arterial pressure. My editorial was unpersuasive, and guidelines have espoused setting tidal volume in terms of milliliters per kilogram. The latest guideline is even more extreme, recommending 4 ml per kilogram, which means an unnatural tidal volume of 280 ml for an average person. The most recent reanalysis of data from the 5 RCTs of high versus low tidal volume have finally come around to stating that tidal volume should not be based on ml per kilogram. When I remarked that the new reanalysis signifies that 6 ml per kilogram should no longer be used in ARDS, the authors, many of whom are co-authors on the most recent guideline, made no attempt to defend continued use of 6 ml per kilogram. So the second past lesson is that a focus on 6 ml per kilogram guidelines is the antithesis of physiological thinking and harmful to patients. The title of my lecture concerns lung protection, which many assume pivots around 6 ml per kilogram. But ironically, I interpret protection to mean shielding patients against the harm caused by 6 ml per kilogram. Many patients with ARDS exhibit double triggering, where the ventilator delivers 2 inflations within a single inspiratory effort made by the patient. Here, esophageal pressure falls and remains negative for more than 1 second, whereas duration of mechanical inflation is 0.6 of a second. The longer duration of neural inspiration as compared with mechanical inflation causes the ventilator to deliver a second breath before there's time for exhalation, producing breath stacking. In this patient, Arrowhead signaled 4 incidents of double triggering, and the width of the esophageal pressure swing is roughly equivalent to the duration of patient neural inspiratory time. On the bottom tracing, patient neural inspiratory time in the double triggered breaths is substantially longer than in the normally triggered breaths. The ARDS network guidelines recommend protocolized low tidal volume in all patients. Protocol advocates ungrounded in physiology do not recognize that low tidal volume is necessarily accompanied by shortening of mechanical inspiratory time. And once mechanical inspiratory time becomes less than neural inspiratory time, double triggering is inevitable. Protocol enthusiasts believe they're delivering tidal volume of 6 ml per kilogram, but the patient is actually receiving 12 ml per kilogram, a setting proven to increase mortality. So this is my third and final past lesson. Beware of Popper's law of unintended consequences. Protocols inadvertently deliver 12 ml per kilogram because they foster double triggering. So turning to present practice, to suss out current approach to lung protective ventilation, experience during the COVID pandemic provides a superb window into present practice. In January 2020, WHO published guidelines specifying that hypoxemic respiratory failure in ARDS usually requires mechanical ventilation. WHO is wrong. Many patients with ARDS are sustained with non-invasive ventilation or supplemental oxygen. Guidelines warned of the risks incurred with non-invasive ventilation, large tidal volumes and injurious transpulmonary pressures, a clear allusion to P-Silly. So what is the science on which the guidelines are founded? The strong warnings against use of non-invasive strategies is apparently based on experience with MERS, Middle East Respiratory Syndrome. MERS is repeated 9 times in this brief document, where pathophysiological principles get zero coverage. Published experience with MERS is based on 12 ICU patients who received mechanical ventilation, 5 of whom were judged to have failed non-invasive ventilation. Not one data point is presented as to why non-invasive ventilation was judged to have failed. In the early weeks of the pandemic, I wrote a brief commentary with practical recommendations based on physiological principles. I forewarned that the surest way to increase COVID mortality is liberal use of intubation and mechanical ventilation. A couple of weeks later, JAMA published this article by Marini and Gattinoni. In this and other articles, Gattinoni advocated radical changes to management based on purported P-Silly, which is an acronym for patient self-inflicted lung injury, the belief that a patient's ability to breathe vigorously can injure alveoli. Specifically, Gattinoni claimed that non-invasive options were of questionable value, that intubation should be prioritized, that delayed intubation causes a P-Silly vortex that induces more severe ARDS, that weaning should be undertaken cautiously and conducted only at the very end of the weaning process. It's impossible to overestimate the influence of this JAMA article at a moment when clinicians craved counsel on the best approach to management of COVID patients. 6 decades of research on how to prudently select settings and remove the ventilator at the earliest time were abrogated on the warrant of an unproven hypothetical entity. Faced with a cannon fight or flight situation, P-Silly provides the pretext for a draconian rejoinder, as treatment of P-Silly consists of intubation, mechanical ventilation, and respiratory muscle rest with neuromuscular blockers. Between June and November 2020, my colleagues and I engaged in debate with Gattinoni on the putative role of P-Silly in COVID in 8 published exchanges. While this debate was going on, several groups reported on the relationship between intubation and mortality. For example, London investigators reported a decrease in mortality from 44% in February-March 2020 to 34% in April-May. Concurrent with the decrease in mortality was a decrease in the rate of intubation from 76% in February-March to 44% in April-May. I commend Dr. Zier and colleagues at Mass General for collecting data as early as March 11, 2020 on 66 intubated ventilated COVID patients. As recommended by WHO, only one patient was managed with high-flow nasal cannula and non-invasive ventilation, and then for less than 1 day. In a subsequent letter to AJRCCM, Dr. Yaroshetsky highlighted the relatively high PO2-FiO2 ratio, outer median of 245, equivalent to a PO2 of 98 on inspired oxygen of 40%, and a median plateau pressure of only 21, prompting Dr. Yaroshetsky to ask a rhetorical question. Do all these patients definitely require mechanical intubation and mechanical ventilation? Despite the median plateau pressure of only 21, all patients were maintained on a tidal volume of less than 6 ml, and 42% received neuromuscular blockers. The Mass General group emphasized their employing EBM best practice. So here we see present practice of mechanical ventilation in ARDS laid bare. Insistence on tidal volume of less than 6 ml in all patients, and the blithe use of neuromuscular blockers in 42%. Turning to present practice, will the reanalysis of the 5 RCTs with a de-emphasis on 6 ml per kilogram lead to a change in clinician practice? I doubt it. Once bad knowledge becomes entrenched in the consciousness of a community, it's extraordinarily difficult to overturn it, like trying to undo damaged threads on a screw. My wish is that doctors will finally recognize the fundamental purpose of a ventilator is to help patients breathe more comfortably. Critically ill patients have inflamed lungs, and stimulation of sensory receptors produces heightened respiratory drive and dyspnea. Dyspneic patients react by attempting deeper inspirations. When a low tidal volume setting impedes this response, intense dyspnea is guaranteed through corollary discharge of neurons in the medulla oblongata transmitted to the cerebral cortex. Dyspnea is amplified by hypercapnia, which is axiomatic to hypoventilation. An increase in PCO2 from 45 to 50 causes an increase in minute ventilation of 25 liters per minute and tremendous air hunger. Patients rebel against being placed on the rack through the constraints of unsatisfying tidal volume by air hunger, and they buck the ventilator. Caregivers use sedatives and paralyzing agents to combat recalcitrant patients and restrain them on the Procrustean bed of 6 ml per kilogram. Do you have difficulty with breathing is the usual opening question when a new patient is first seen in pulmonary clinic. The word dyspnea has been employed by authors for centuries and appears in the writings of Laennec, Stokes, Flint, and Osler. Etymologically, the word stems from the Greek for difficult breathing. In a study published a few months ago, we found that patients undergoing a trial of weaning experienced intense dyspnea and a 3-fold increase in work of breathing. Despite difficulty being the essential attribute contained in the word dyspnea, only 16% of our patients choose too much effort to breathe to describe their discomfort, whereas 83% selected not getting enough air. The setting of tidal volume was lower in the dyspneic patients than in the non-dyspneic patients. Despite a 3-fold increase in work of breathing, dyspnea bore no relationship to any measurement of patient effort. So whereas doctors interpret dyspnea as difficult or laborious breathing, patients perceive it as starvation of air. Sedative agents don't relieve dyspnea, Neuromuscular blockers don't relieve dyspnea. Indeed, they aggravate dyspnea by removing behavioral clues that alert caregivers to patient discomfort. So how should a doctor set tidal volume in a patient with ARDS? 6 ml per kilogram has zero physiological foundation and is the source of torment in many patients. Tidal volume needs to be customized for each patient based on physiology and comfort. If a plateau pressure is above 30, I decrease tidal volume, bringing plateau as low as possible while avoiding double triggering. I aim for plateau of less than 28. When plateau pressure is in the low 20s, which is the case for most ventilated patients, the use of unnaturally low tidal volumes contravenes every principle of physiology. So my coda is to say mechanical ventilation is closely allied with intensive care medicine is the wrong orientation, a form of the tail wagging the dog. Without mechanical ventilation, intensivists would not exist. ICUs emerged in the 1960s as distinct locations to safely deliver mechanical ventilation. Over the next 60 years, rigorous research generated principles on how to prudently select settings and remove the ventilator at the earliest time. During the COVID pandemic, this knowledge was abrogated and thrown out the window on the warrant of an unproven hypothetical entity, and patients were subjected to life-threatening practices in the use of mechanical ventilation. Thank you.
Thank you so much, Professor Tobin, for this excellent and thought-provoking talk. Anyone who has questions can certainly add them in the chat, and we'll have time for questions at the end. But now at this time, it is my pleasure to introduce Professor Laurent Brochard. He's the immediate past director of the Interdepartmental Division of Critical Care Medicine at the University of Toronto. He is a full professor and clinician scientist in the Division of Critical Care Medicine at St. Michael's Hospital, and was editor-in-chief of the journal Intensive Care Medicine from 2001 to 2007, and is currently serving as deputy editor for the American Journal of Respiratory and Critical Care Medicine. Professor Brochard is one of the world's greatest experts in respiratory physiology, and his extensive research program spans everything from bench models of respiratory failure to single-center physiologic studies to large-scale RCTs, defining the management of respiratory failure in the ICU. Welcome, Professor Brochard, and the floor is yours.
Okay, thank you very much, Richard, and thanks for the invitation for this interesting title about precision mechanical ventilation in ARDS. As you asked for conflict of interest, my laboratory has been working with a number of companies to get research grants or equipment, and they are listed here. So randomized clinical trials are definitely important in our field. They have many limitations, and they cannot address many of the questions we ask ourselves when we treat a patient in the ICU. And as already discussed, some of these trials, like the ARMA trial comparing two tidal volumes, were kind of proof of concept and not a way to titrate the mechanical ventilation settings. So we need in our field, and that's very particular in our field, we need a lot of physiology, and we need experimental physiology, we need animal trials, which is different from other fields, which explains some of our approaches to what we call evidence. So one thing I try to explain usually with physicians is that the ventilator is is a very useful treatment, but is also a very useful tool to understand your patient. And if we need to decide about physiology and individualized settings, you shouldn't miss the opportunity to use the ventilator as a way to better understand your patient. So one very simple technique, and I'm going to start with something very basics. I apologize in advance, is to use the pause at the end of insufflation as a pulmonary function test. Because having this pause differentiate the peak pressure from what we call the plateau pressure, allows to separate the resistive and elastic component and do a number of calculations which may be useful for setting the ventilator. And in particular, it gives access to the pressure in the alveoli at the end of inflation, and we call it the plateau pressure. And it also allows to measure the driving pressure, the difference between this pressure and the starting pressure or the pressure at the end of expiration. And just a practical point, just to say, usually people measure the plateau pressure with a long pause, which I don't think is necessary for different reasons. The long pause will give you a different value than a short pause. And my recommendation would be to use a short pause at every breath of 0.2 or 0.3 seconds, because it will be closer to the peak alveolar pressure, which is probably more relevant for questions of injury due to the ventilator. So let's go again, very basics to the notions of compliance and driving pressure, which we calculate at the bedside as a ratio of the tidal volume to the driving pressure. Luciano Gattinoni has been really the pioneer in this field, showing with CT scan that the reason why we have high pressure, i.e. low compliance in patients with ARDS under mechanical ventilation, is not because of the stiffness of the lung, but because of the reduced aeration of the lung. And he showed very nicely that the lower is the amount of aerated lung on the CT, the lower is the compliance. So if you wish, you can imagine compliance as being the sum of the multiple compliance of all the subunits in the lung. And if you have a patient who has a compliance of 100 milliliter per centimeters of water, you could imagine like it's like having 100 subunits with each one being 1 milliliter per centimeters of water. And why do I say that? Because as you have seen on the CT scan, maybe 2/3 of the lungs were not aerated, were not available for ventilation. So if you have only 30 units left in this very particular patient, your compliance will be 30 ml per centimeters of water. The issue with compliance is that it depends on the initial size of the lung. And one interesting approach is to try to normalize this value of compliance, which maybe can mean different things in a very tall guy compared to a small old lady in the ICU. And the way to normalize is, instead of using tidal volume, you could use tidal volume not in milliliter, but in milliliter per kilogram of predicted body weight, which is the way to adjust for the size of the lung. And the beauty of it is that a normalized normal compliance should be around 1, which means driving pressure of 6 for a tidal volume predicted body weight of 6, or a compliance of 60 for someone with a predicted body weight of 60 kilo. And I like it because this is the same value, whatever the age range. So if you go to a kid or to a neonate, you will have the same normalized, normal compliance. And a premature baby may have a compliance of 1 milliliter per kilogram per centimeters of water, because his weight is actually 1 kilogram. And of course, you can use also elastance, which is the opposite of compliance. And you can express also the normalized elastance being around 1. And the reason I saying that is that in this study led by Johan Golliger, this was a reanalysis of the different trials which compared low tidal volume to high tidal volume. And the model was computing the probability of death using a high tidal volume or low tidal volume, the blue curve versus the red curve, according to this normalized elastance. And remember, normalized elastance around 1, 1.5 is very close to a normal value. And you see that the benefit in terms of mortality of decreasing tidal volume was very high for high elastance value, but became almost zero or even negative, suggesting harm of the low tidal volume for the normalized elastance close to normal. So that's a very interesting approach, different from the 6 ml for everybody, 6 ml per kilogram of predicted body weight for everybody, to better individualize the approach of setting the tidal volume. And in the same line, the tidal volume could be also kind of normalized by the same calculation. If the compliance is tidal volume divided by driving pressure, it means that driving pressure is tidal volume divided by compliance. And as we saw, compliance is a reflex lung volume. So with driving pressure, you have a direct estimate of the ratio of what you set as a clinician to the lung volume available for ventilation. And it's no surprise that in almost all studies looking at data set from randomized trials or from observational studies, the driving pressure became the most, the parameter the most often and most strongly associated with outcomes, suggesting that it's associated also maybe with ventilator-induced lung injury. So if you want to know more, you may think about an additional factor explaining the alveolar pressure, because the alveolar pressure is reflected by the plateau, but it may be also influenced by the weight of the chest wall. When I say that, I'm not talking of a stiff chest wall, but simply a heavy chest wall like in obese patients. And in obese patients, the alveolar pressure may be influenced directly by the weight of the chest wall. Another interesting approach that you can detect at the bedside to your patient is that, and it's sometime in relation with this chest wall, the airway may not remain open during expiration, but may close probably centrally. We noticed that with Lu Chen when doing her study on recruitability, that most patients, when you do a low flow inflation, which means it mostly reflects the elastic pressure, so you inflate the lung very slowly, you see the patient and the pressure and the volume going concomitantly. However, in some patients, what you observe, and we saw that in 30% of the patients, as I mentioned, it's more frequent in obese patients, maybe 40 to 50%. We saw this phenomenon where the first part was simply the inflation of the tubing of the ventilator. And abruptly, the airways open, and we found that there were pressure which indicated the reopening of the airway, which could be anywhere between 5 and 25 centimeters of water. This is another example of patient. Really interesting and intriguing, and suggesting that maybe in this patient, the PEEP should be set at this airway opening pressure just to keep the airway open. You don't need a pressure volume loop. You can do just a simple low flow inflation, like shown on this graph, where the flow is just decreased for the low inflation, and you see the abrupt increase at the beginning of the breath. Again, in this patient, the opening pressure is around maybe 19 centimeters of water. So nothing happened in the chest before you reach 19 centimeters of water. This is a nice example in a patient who underwent ECMO, and you see the opening pressure is around 20 centimeters of water. So very important clinical information which can be obtained easily at the bedside. To finish this part, I would say we can also use these measurements to detect whether the patient has a recruitable lung or not recruitable lung, which to me has been lacking for many years since we use PEEP in hypoxemic patients. And of course, the CT scan has shown that some patients are recruitable, some are not recruitable, but this is not feasible as a monitoring tool. So we develop a simple technique where in one breath, we decrease the PEEP from 15 to 5. We measure the expired volume. And from this expired volume, we simply look at whether this is simply due to the distension by the 10 centimeters of water of PEEP by calculating the compliance at low PEEP, or does it contain some de-recruitment going with this drop in PEEP? And this technique has been described in detail. You can also find it on this website called rtmaven.com. I won't pass this video, but this is a 1-minute video showing in real time how you can do the measurements. And it gives you an orientation whether the lung is more recruitable or less recruitable. There have been a number of validations. So when the value is in her hands below 0.5 or around 0.5, the lung is not recruitable, and the suggestion is to stop trying to increase the PEEP. Whereas when the recruitment to inflation ratio is higher, it may be worth to try to increase the PEEP. Just to show a recent, really interesting kind of validation showing that the hemodynamic effect of increasing PEEP, so comparison of low PEEP to high PEEP, had no hemodynamic effect on pulmonary vascular resistance in patients who were recruitable, but has a strong hemodynamic effect with increase in PVR in patients who were low recruiters. So just to finish, I think to characterize your patient, one really interesting thing is imaging. And as I mentioned, CT scan is not a monitoring technique and is even complicated to interpret. Since a number of years, we have available a new technique called electric impedance tomography, which is based on the change in impedance in the chest, so the transmission of small electric current, if you wish. And of course, this change is mostly related to the change in volume, in gas volume. So the signal coming from this change in impedance can be transformed into change in ventilation. So it looks like a CT scan, but of course it's very different because it's not anatomical, it's functional. But it tells you where the ventilation goes and how it is modified by your pressure settings, by the position of the patient, or by spontaneous breathing. And really, this is a big step forward in our field. I'm just going to show you two examples. One is a study we did in a laboratory which was run by Brian Kavanagh, who unfortunately passed away in Toronto. And the first author was Bhushan Katira. He did a model of lung injury, an animal model in pigs. And what is shown on the left is the curve of compliance over PEEP. This is what we call a decremental PEEP trial from 20 to 3 centimeters of water. And the curve at the top indicates when we reach the best compliance for the whole lung. And you see for this animal with lung injury, the best compliance was around a PEEP of 15. However, with EIT, we can separate the dependent and the non-dependent part. And what you can see is that the white dots indicate the dependent part. And again, the best compliance for this part is around 15 centimeters of water. But if you look now at the non-dependent part, which is more prone to distension, the best PEEP maybe was around 7 to 8 centimeters of water. So there is no way that one PEEP will be best for the whole lung. Well, except maybe what you see on the right is when the animal was put prone, like a very nice feature where the two parts of the lung were much more homogeneous, a major benefit of prone ventilation. What's interesting also with this technique is that you can look at every single pixel in the image, and each pixel can be considered as individual value, where you can see how the volume change or the impedance transferred into volume with the constant delta pressure. And if the pressure, the volume over pressure goes down, it means that the compliance goes down and that it's more probably a collapse of this alveoli, of this pixel. Whereas if when you decrease the PEEP, the compliance goes up, it means that there was distension of this, over distension of this pixel. So you can create a curve, and if you look here on the left, of the all compliance pixels, and all pixels which are distended, that would be the blue curve from 20 to 5 of PEEP, and all pixels will start to collapse. And as you can see, you can determine a crossing point, we call it, where you have the best compromise between collapse and distension. This is the example of high recruiter patients where the best compromise would be at 15 centimeters of water. And this is an example of a low recruiter patients where the best compromise would be around 7 centimeters of water. And we showed it's feasible. This is a study we did, a multicentric study in more than 108 patients with COVID. And we found that the recruitability was enormously different from patient to patient. Some patients have 0 to 10% of recruitability, whereas some patients had more than 50%. So exactly reproducing the data from Luciano Gattinoni with CT scan, but with a much simpler technique. And we, just to show you, this is an illustration when we separated the patient into 3 groups: low recruitability, medium recruitability, high recruitability. And the crossing points were different in terms of PEEP level. But what's fascinating to me is that whatever the point where the 2 curves cross, it's always indicating of less than 10% of collapse and less than 10% of distension. Because we don't know what's the most risky for the patient, whether it's collapse or distension. That's a nice way to give a compromise. Is it good for the patient? Well, it seems to be good for the lung, but it may be also good for the hemodynamics. You remember the classical curve of pulmonary vascular resistance over lung volume. In lung injury, we don't know where is the best lung volume. And we found that the lower pulmonary artery pressure in these experiments was where the EIT had the crossing point. And this is 2 different models of lung injury. So very attractive technique maybe to minimize the harm of over-distension or under-recruitment. So in terms of this data about PEEP, just say there's no optimal PEEP, and there's certainly no unique optimal PEEP for all regions of the lung. Knowing whether the lung is recruitable or not is really a very important individual step for your patient. We found that insufficient and excessive PEEP have serious negative consequences on the right ventricle, and EIT may offer an optimal compromise for PEEP titration. So hope I showed you some example of how in the individual patient you can better give precision mechanical ventilation. Thank you very much.
Well, many thanks to both Professors Tobin and Professor Brochard for 2 enlightening and really, really fascinating discussions. I see there's a number of questions already in the chat and in the Q&A. Maybe I'll start off with one of the questions just from the chat, which was just asking about elastance, sort of recognizing the importance of the patient's individual physiology. How can clinicians actually use elastance when they're at the bedside and making decisions rather than just focusing on sort of the standard 6 cc's per kilogram? I'd just love to hear both of your thoughts. Maybe Professor Brochard, do you want to start us off, and then Professor Tobin, would love to hear from you after.
So the concept of elastance is the same than driving pressure, right? So it's just looking at these two values, the plateau pressure and the driving pressure. The plateau pressure is really already a first interesting index because it's the alveolar pressure, and it's, to me, I see many clinicians who don't realize that this is a pressure in the alveoli, which matters for lung injury and which matters for circulation. But the alveolar pressure can be influenced by the chest wall, and the driving pressure is such a simple index. It has some limitation because you may need to check whether there is a different total PEEP than the actual PEEP, and whether there is airway closure. So that's why we are promoting that. But the higher the driving pressure, the higher the plateau pressure, the more concerned you should be about the tidal volume. But many patients, you will find these values are relatively low, and you should not certainly try to keep the tidal volume low, because the patient will not like that, and be much more liberal with your targets of tidal volume. So these calculations at the bedside have direct implications. And just to finish, we and others show that it's interesting that during pressure support, for instance, because many people use pressure support, you can still do a plateau at the end of insufflation. But the plateau will be higher than your peak pressure because it will contain the elastic pressure during the inflation and the elastic work done by the patient to inflate the lung at the same time. So you will see more plateau pressure than your peak pressure, which may be a surprise for many. And it's easy to do because maybe because of what we call the Herring-Breuer reflex, but many patients will be very relaxed at the time you do this plateau. So you can reliably still measure compliance or elastance if you prefer during that time, or you can reliably measure the plateau pressure, and this can guide you to say whether the tidal volume is acceptable or not.
Thank you for Professor Brochard. Professor Tobin, anything to add on how you use elastance at the bedside? And I think we'll just need you to unmute there, Professor Tobin.
Martin, you're muted.
Professor
Martin.
Tobin, you're muted there. We're not able to hear you.
Yeah. Okay, I'm sorry. Does it work now?
Yeah.
Perfectly. Thank you.
I'm sorry. All right. So, I mean, you have the same concept with different words, whether you call it plateau pressure, driving pressure, elastance. These are all basically different words for the same concept. And in a small number of patients on the ventilator, you're going to be very worried about high plateaus or high driving pressures. But the vast majority of patients don't have these high values. And so again, the primary purpose of somebody on the ventilator is to try and make the patient comfortable. And so kind of a focus on the driving pressure for most patients, to me, is erroneous. There's only a small number of them where this is a big problem. For the vast majority of them, what you primarily need to do is make the patient comfortable. And that's going to be largely related to the size of the tidal volume. So when you're using very low tidal volumes, like 6 ml, automatically in all patients, you're going to end up torturing the patient. And so it's important that in the majority of the patients that you are customize the size of the tidal volume for the patient. There's an art involved in medicine. It's not, you need to figure out what to do for the patient at the bedside. That's all.
Thank you, Professor Tobin. And this brings me to one of the questions from our viewers on LinkedIn. This is from Ravi Agarwala. There has been a lot of attention on how to set initial PEEP, but very little on how to wean the PEEP. What will be your approach?
I mean, again, in many patients, it is that you lower the PEEP, and you will see in some that you will get an immediate drop in the oxygen saturation. And I mean, I use the 3-minute rule, basically. I've been using this since back in the 80s. And it is, you know, in those patients, if they have a rapid desaturation, you just jack up the PEEP again. So you do this at the bedside, looking at the pulse oximeter. And again, in the majority of patients, you can lower the PEEP without trouble. But then there's going to be some where you're going to get into trouble, and then you bring it back up. And so you have to adjust from hour to hour, day to day, and you see when is the patient able to do this.
Thank you. Back to you, Richard.
Yeah, maybe just a follow-up question on PEEP. A question for you, Professor Brochard. We received a question asking about regional heterogeneity and EIT, where if you're sort of seeing different, sort of the compliance is different in different regions of the lung, and so the crossing point might be different with that regional heterogeneity. How do you use EIT to set the PEEP in the setting or in the face of such impressive heterogeneity?
Yeah, the lung is always heterogeneous. So that's it's very clear there is no single PEEP which is good for the whole lung, and there is a heterogeneity due to gravity. So the pleural pressure is always higher at the bottom than the top, which explain this distribution of ARDS we see with the condensation at the back. The question is, if you try to recruit, let's say, to reopen this part, what are you going to achieve in terms of re-ventilating this part, but also in terms of distending the other part? And I have to say, this is something we see quite well with EIT, and we've noticed a number of patients where, for instance, in animals, that's different, right? But in animals, you can test any PEEP you want. And we have seen the best way to homogenize the lung, to make the lung perfectly homogeneous, is to use very high PEEP, because you will distend everything, and so it will be very heterogeneous. So I'm just warning against trying to homogenize the lung absolutely, because you can easily do that by simply distending the part which is already open. And once it is distended, the ventilation also goes down. So EIT is an interesting technique to see that. For instance, we published a paper with Takeshi Yoshida where we say, well, just looking at the distribution of ventilation, right away it can be an incentive to decrease the PEEP, because you see that for instance, if you see that the ventilation goes more dorsal than ventral, the number one reason is that you over-distend the ventral. So you can use the technique I described of the crossing point, which is kind of finding a compromise. And again, we do that because we don't know what's worst. Or you can simply look at the distribution of ventilation and how it changed with PEEP. And if you see more dorsal ventilation than ventral, that's usually bad. That means you over-distend the ventral part.
Yeah, thank you. Professor Mina, were there particular questions that you wanted to highlight?
Yes, and actually, there's a question about the trigger to decide proning in the ARDS. We use PF ratio. Is there any role using lessons as indication to decide to prone the patient? Either one of them.
Martin, you want to start?
Professor Tobin or?
Yep.
I would say, as you've seen, for instance, in the graph with the difference between dependent and non-dependent in supine and then in prone, it looks like a fantastic technique. The difficulty is that is that usually we keep patients deeply sedated for that, and we keep patients even paralyzed. So which is a downside, right? So we don't want to do that too quickly. So the data from the PROSEVA study from Claude Guérin suggested, based on PF ratio, that the strongest effect, the strongest benefit was in the category of PF ratio between 150 and 100. Was still beneficial below 100. So that's why the PF ratio of 150 has been chosen as well, initially it was 100, and now I think the recommendations say 150. So I think you can start with that, saying, oh, this patient is worsening, going down, and the PF ratio is below 150, so we should think about proning. But you should look at the trajectory of the patient. If the patient is improving and awakening, proning may need to go to sedation and paralysis, which is a limitation.
I mean, my comments here would be that in an individual patient, it's impossible to predict what's going to happen. Sometimes it's trial and error in terms of proning. So, I mean, there's patients that improve dramatically once you turn them prone, and then there's others that deteriorate and others that stay the same. And there may be kind of signals that you're seeing in general when you aggregate patients, but in the individual patient, it's back to trial and error. And you try it again, which Laurent has touched on. The big problem is that with proning, you're going to markedly increase the likelihood that you're using neuromuscular blockers. And neuromuscular blockers are a very heavy price to pay in patients. That you're going to have accidental disconnects, and then the patient is dead when you get an accidental disconnect with a neuromuscular blocker.
Yeah, there were really interesting data in COVID patients showing that some patients had, let's say, a consolidation which did not reopen during proning. So what you expect is that most of the consolidation are gravity dependent and will change with proning. But if part of this consolidation are pus or infection, they will not reopen, and then you will have the gravity dependent at the bottom plus the one which were the real consolidation, which will not reopen, and that will aggravate the gas exchange, for instance.
Javier?
Yes, I have one more question from LinkedIn. This is from Professor Barry Ransom at Rowan University. Is there a way to accurately estimate transpulmonary pressure without esophageal pressure monitoring to help differentiate between lung and chest wall compliance?
My feeling is no. There is no, and I don't think esophageal pressure is such a big deal. So we are lucky enough to have now different ventilators which offer modules to make it easier, and because it's very nice when you have the airway pressure, the esophageal pressure, the calculation of the difference, which is the transpulmonary pressure, on the same screen with the same scale. So you immediately see. So I would say no, but that's my experience.
Again, I think the point is that in many patients, when you're looking at the plateau pressure, driving pressure, whatever, these are going to be low. So the question doesn't arise. In some patients, the driving pressure, plateau pressure is high, and then you certainly do need to be worried about how much of it is coming from the chest wall. And again, if in an average patient, if they're not fat or they don't have ascites or something like that, again, you're going to be excluding that part. But again, in others of them, and then you certainly have to consider it. And as Laurent points out, the way to do it is with the transpulmonary pressure. But this is only going to be applying in a small proportion of the patients.
Richard, any one last? Actually, it's 4 o'clock.
Yeah, I think we should close things up then.
Yeah, definitely. Dr. Mina, if you can do the closing remarks.
Thank you, Professor Tobin and Professor Brochard, for the exceptional contribution, and thank you, Dr. Greendick, for moderating today's session. On behalf of my co-chair, Javier, and the SCCM ARDS Innovation CAG, I would like to thank our global audience for joining us. With participants spanning multiple continents, these webinars embody our mission to advance knowledge, foster collaboration, and improve outcomes in ARDS. Please follow SCCM and ARDS Innovation CAG to stay updated on future sessions, recordings, and resources. Thank you again, and we look forward to seeing you at our next webinar. Thank you, everybody.